I might start. I've just seen an email, someone saying, don't stress. I thought, oh, why should I stress? Anyway, welcome everybody. Good morning, good afternoon, and good evening, according to wherever you are. My name is Bernadette Watson, and I'm Director of the International Research Centre for the Advancement of Health Communication at Hong Kong PolyU. It's a joint faculty centre, and it's attached to the Faculty of Humanities as well as the Faculty of Health and Social Sciences. The centre's goal is to bring together researchers from different disciplines in health communication and to connect with our community in Hong Kong and with clinicians from different health professions. Because we are a research centre that is applied, we want our research to translate into meaningful outcomes and improved patient care. For that reason, it gives me great pleasure to be able to introduce our centre's first speaker, distinguished speaker of our series that the centre wants to put together. Professor Terry Thompson is a very applied researcher and always wants to make a difference. Dr. Thompson is the founding editor of the journal Health Communication, which is an A-star journal. She has edited the journal since 1989, and she has co-edited 3 editions of the Routledge Handbook of Health Communication. She has also served as an editor of the 3 volumes Sage Encyclopedia of Health Communication. She's published well over 75 articles in such journals as Human Communication Research, Communication Quarterly, Public Opinion Quarterly, and many others. She has been honoured by both the National Communication Association and the International Communication Association for her work in health communication. She received the annual Alumni Award in Teaching at the University of Dayton and the College of Arts and Sciences Scholar of the Year Award from the university. Her current work focuses on communication issues relevant to COVID-19, which is really important. COVID-19 and ethics in health communication. She's also presently teaching for the University of Kansas. It gives me great pleasure, and I really mean this, to introduce Professor Terry Thompson, who will talk on current trends in health communication, the arrival of the 3rd edition of the Routledge Handbook of Health Communication. Over to you, Terry.
Thank you, Bernadette. Thank you very much. I am delighted to be here with you today. I just wish that I could be in Hong Kong with you. Right now, I'm in Kansas City, Kansas, to take care of my mother, which is not nearly as fun as Hong Kong. So hopefully I will be able to be there with you at some time soon. When Bernadette asked me to speak, we talked about the latest edition, which, goodness, just came out last week, the week before, of the Routledge Handbook of Health Communication as an organizing frame. We thought that would be useful both for those of you who are new to the study of health communication and those of you who are well established in the field and might want to know what kinds of things we are covering in this new edition of the handbook. It also seemed like it would be a good way to organize a presentation to bring people up to date on what's going on in health communication. As Bernadette mentioned, I'm editor of the journal Health Communication, and never thought I would be editing it for as long as I have. I was pregnant with my daughter when I first started accepting submissions or soliciting submissions, receiving submissions, and she will be 34 before long. So it's been ongoing. 3 handbooks of health communication have been around now since the early part of this new millennium. The first edition came out in 2003. I was at, I believe it was an NCA conference. It was probably SCA, Speech Community, yes, SCA, the Speech Communication Association at that time, having lunch with my publisher, who said, you know what we really need now? The journal had been around for a few years at this point, and she said, we're ready for a handbook of health communication. I said, oh, yes, what a great idea. I'm not going to do it, but that's really a great idea. Well, of course, as we do, I went back to the hotel room and thought I would take a nap, but instead started outlining this first handbook. And before I knew it, had contacted some other people about co-editing it with me, and on it went. The second edition came out in 2011, and this third edition just a couple of weeks ago. Nancy Grant Harrington is my co-editor on this book. I think you will see, those of you who are familiar with all 3 editions, that this edition is even better because Nancy is such a great editor. So I hope that's apparent to you as well. Here's a picture of the third edition. The cover doesn't look all that different than did the cover of the second edition, which I find slightly amusing, because for the second edition, we used a picture that Roxy Parrott, one of the co-editors for the first 2 editions, had taken on her own and put it on. It was lovely. For this one, Nancy did much more work on obtaining a picture. She found a photographer whose work she really liked, an independent photographer who she wanted to support, and she looked through all of his pictures, and we bought the picture from him, and it doesn't look all that different than did the second edition. Don't tell Nancy that I said that, though. It's a lovely cover, but I just got a little bit of a kick out of that. So we start, of course, with Introductory Issues, an opening chapter by Alyssa Cohen on the multidisciplinary, interdisciplinary, and transdisciplinary nature of health communication. These are not issues that will be new to those of you who are well established in the field, but it does a very nice job of casting how we work in health communication with and across other fields. Then Nancy and 2 of her colleagues at the University of Kentucky wrote the second chapter on some important theoretical and methodological considerations, beginning with the notion of meta-theory, talking about ontology, epistemology, praxeology, axiology, all the ologies. Well, not all the ologies. There are probably a lot of ologies that we didn't cover. They did something very important in this chapter that we then tried to carry through the remainder of the volume, talking about the 3 key paradigms that we use in health communication research: social scientific, interpretive, and critical cultural. We asked all of the authors to comment on the role of these 3 paradigms in their chapters. Some of the chapters rely almost exclusively on more social scientific work. Others incorporate more interpretive, critical, cultural, but it's something that we tried to have all of the authors address at least a bit in their chapters. They also talk in this chapter about a few methodological issues. We did try to be much more conscious in this edition of the book about diversity concerns than we've ever been before. I think we could have done much better. As I was looking back on it the last couple of days, I had some additional ideas about that, but perhaps the fourth edition, on which I do not plan to be the lead author. Let me just get that clear at this point, although I recall I said after the second edition that I was not going to do a third edition, and apparently I forgot that at some point. The third chapter then talks about some very important issues of translation, dissemination, and implementation. Some themes that we began in the second edition and have become even more important as our research has moved on. And then a focus in the fourth chapter on narrative issues. Lynn Harder has been one of the authors of all three of the versions of the chapters on narrative, but they continue to evolve in really interesting ways. I love how the narrative work focuses on tying stories into well-being, humanizing healthcare, and catalyzing change. And there's even more emphasis in this edition on that notion of change, on disrupting and modeling. So I think a lot of you will find that exciting. So we've got a picture. I tried to put a few pictures in just to keep things interesting. We've got a storyteller here. Does she look like a storyteller? I hope so. That was the plan. The second part of the book moves then into interpersonal and family health communication issues. Another new chapter, mental health, mental illness, and suicide. Wow, can't get too much more important than this. At the time that we began inviting authors to write the chapters, and by the time contracts were set, at the time we began writing, let me rephrase that, we did not yet know much about COVID-19. Obviously, mental health and mental illness became much more important during the pandemic, and we tried to present all of the chapters in a way that acknowledge the relevance of COVID-19 during the writing without presenting the issues or the chapters in a way that would make them dated fairly soon, although it doesn't look like COVID is going away fairly quickly. We'd all like to think that we're in the post-pandemic area. I heard someone say that just today, but we know better than that. We're not. We are still in the midst of the pandemic with all that it tells us about so many health communication issues. I just tonight did the final acceptance. It's nighttime where I am. Just did the final acceptance on a great COVID piece that I'm hoping will be the first article, the lead article in the first issue of 2022. So coming out in January, that really does a great job of bringing together for us much of what we have learned about health communication as a result of the work that's been done during the COVID pandemic. Jali Nen, one of the senior editors for the journal, is the lead author of that piece. So that's something for you to all look forward to. One of the disappointments that I have had about the work on mental health, mental illness and health communication is that we are still spending too much time talking about the fact that we need to study this without actually studying it from a health communication perspective. So I am hopeful that some of you will be working on this. So a new contribution, a great chapter, although I don't think we have a weak chapter in the bunch. They were really all wonderful. We have someone here who looks suicidal, I think. Do you think so? That's why I included the picture. The next chapter continues the theme that's been in the last couple of yearbooks about stigma, communication, and health. I was the first person in the field of communication to study stigma. So this is near and dear to my heart, but I have not written any of these chapters. Rachel Smith from Penn State is the brains of this line of research, although I thought it was very kind that she did cite my earliest work going all the way back to the late 70s. Don't you think that was nice? Of her. I thought that it was. My interest stemmed from work in disability. So I include a picture representing that in the PowerPoint, but stigma obviously applies to a wide variety of health communication issues beyond disability concerns. This next one is also near and dear to my heart: health and relational outcomes for informal caregivers and care recipients. I mentioned I moved to Kansas City to take care of my mother, who never thought she would live to be 91 and a half. She's in the next room. So I retired a little early from the University of Dayton, moved here. The family had moved to Kansas City in 1972. And I'm just now catching up with them. I'm now an informal caregiver for my mother, who thought maybe she would live to be 72, and here she is heading towards 90 too. So you can see why this one is near and dear to my heart. This chapter is interesting in that it does a great job of presenting the positive outcomes, both in terms of health and relationships for both informal caregivers and care recipients. This is important because we spend so much time, especially those of us who do the caregiving, focusing on how hard it is and the difficulties and the stress and the burnout. And I better stop right here, or I will get too carried away. But Jacqueline Harvey and two of her colleagues do a great job in this chapter of also discussing some of the positive outcomes. We see a multi-generational family here. The next chapter by Maureen Keeley and one of her former master's students, who's now working on her doctorate at Rutgers, focuses more broadly on family health communication. It talks about the need for a systemic perspective, notions of sense-making, and family health narratives, communication patterns. They also, in this chapter, talk about informal caregiving, because, of course, that's such an important part for so many of us about family communication. Then they conclude this chapter with discussions of resilience and moral dilemmas. Very exciting. Continuing with this theme, we move on to a chapter on palliative care and end-of-life communication. Joy Goldsmith and Elaine Wittenberg discuss their comfort model in this chapter and identify many of the barriers to palliative care and end-of-life communication and some of the cultural differences. So this is a continuation of a long-term line of research in which Joy and Elaine have been engaging. So we have another wonderful chapter here. We see a caregiver and a kind of older patient here. Then Erin McGeorge and one of her grad students wrote a great chapter for us on social support, supportive communication, and health. This is one of several places in the book in which social support is discussed because, of course, it's such an important topic for us within all aspects of communication, but I think especially in terms of health communication. They talk about both emotional and esteem support, informational support, and advice received versus enacted advice. Particularly interesting, I think, what support do I think I am giving to someone else compared to what support do they perceive that they are receiving. They can, of course, be two very different things. And then, as you would imagine, this chapter also includes a discussion of support in online contexts, as those are so important to us. So we've got someone supporting someone else here. In all three editions of the handbook, we've had a chapter on everyday interpersonal communication about health and illness. Becky Klein wrote the first two chapters. I tried to get her to write a book on this topic, but I was never successful. Darn it. So I hope you will keep that in mind. If I suggest to you that you should write a book about something, it's probably a good idea. As a matter of fact, I had a Zoom meeting this morning, my time, with a publisher to whom I mentioned a couple of you who are probably listening right now. So if you get contacted, take those suggestions seriously. I've been really struck by how publication opportunities, outlets, books, etc., shape any field of study. Having been such a long-term editor, I had no idea that having a journal in which health communication research could be published would so change the field of study. We have seen people from such a variety of backgrounds turn their interests to the health context because there was an outlet. We've seen, what do we have? 3, 4, 5 additional journals now focusing on health communication. I was quite unhappy with Scott Ratson when he first started the Journal of Health Communication, thinking, oh, no, there will not be enough research to go around. I was completely wrong. Not only is there enough research to go around, but we still all have very low acceptance rates, high rejection rates. We continue to increase each year the number of submissions that we get, the number of articles that we publish. Last year in health communication, we received almost 1,300 submissions. Obviously, people who were quarantining and sheltering devoted their time to doing health communication research, and it's been wonderful. We already have broken 1,000 submissions for this year, so it looks like we are heading close to that 1,300 again. So back to the topic then, everyday interpersonal communication. Becky Klein has now retired, and 2 young scholars, or is it 3? I think it's 3. Katie Head and Jen Butte and one of them, Marias. We've got several Marias active in our field. They're all at IUPUI, wrote a great chapter on everyday interpersonal communication from an even broader perspective than we had seen presented in the previous 2 editions. We then move on in the book to a section, as you would guess, on provider-patient communication. Jen Freitag and Rick Scott, who never writes what I ask him to and always does something much better than what I've asked him to do, wrote a great chapter on patient-centered communication, focusing on it as mutual persuasion. Doesn't that sound exciting? Well, it is. It's just as exciting as it sounds. So they talk about influence, persuasion, and then mutual influence, how the provider and the patient influence each other as important parts of patient-centered communication. We all know that we've been talking about patient-centered communication for quite some time now. So it's nice to see this new take on it. They tie it in, of course, to the work on shared decision-making and relational autonomy, and conclude the chapter with a discussion of moving toward shared mind. Get just as exciting as you think it would be. Here we see a picture of the patient and provider moving toward shared mind. That's what this says to me. Then another new chapter, difficult conversations. Healthcare providers have been talking about difficult patients for a long time. That's a long-term line of research. But when we take a communication perspective, we focus more broadly on how conversations can be difficult rather than just patients or providers individually being difficult. So this chapter nicely covers that dyadic perspective that's so important for us in communication. This chapter is authored by Allison Scott, a young, by my standards, although she's got 4 kids now, so I guess she can't be quite as young as some of us might think of when I use that term. Allison Scott wrote this chapter. She was building on a line of research that she and Nancy Grant Harrington have begun. They had a great piece last year in Social Science and Medicine that some of you might have come across on cost of care conversations, one of those difficult conversations. In this chapter, then, she expands that focus, talks about sensitive disclosures, challenging context, high stakes decisions, various charged topics, and then moves on to some strategies that are important for us to keep in mind as we engage in these kinds of conversations, identifying the barriers, describing the context, explicating meaning and function, and predicting the outcomes of these communication. I think this must be part of a difficult conversation. I really had planned to put a provider-patient picture in here, but I liked this one so much I couldn't resist. You're lucky I didn't put any pictures of my grandkids. And I almost did. All right. The next chapter focuses on improving clinician and patient communication skills. I'm guessing that all of you know the importance of skill development in the field of health communication. Karma Byland, who's now at the University of Florida, and Brianna Cusano, who's a doctoral as a student, although, talk about a really good doctoral student at University of South Florida, and one of their other colleagues took the lead on this piece. Really a very nice contribution. They begin with talking about the philosophical underpinnings of the skill development research, various pedagogical methods that we use, assessment and evaluation. And as I'm sure most of you know, most of the work on CSPs, communication skill programs, focuses on care providers, but more and more slowly is beginning to focus on patient communication skill development. Don Segala and some of his colleagues and students originally began that line of research. They conclude this chapter by talking about cultural competence and humility. Really important topics. That I think that's my favorite part of this chapter, and I love the whole chapter. I wrote something recently myself on CSPs and kind of stole some of their ideas, but don't tell anybody that. So we've got some care providers in training here. Then a chapter on a topic that I always like, tying communication into outcomes. Kelly Heskard Zolnarian, I never can pronounce her last name, is the lead author on this. She was one of Robin DiMatteo's students, so I'm guessing that a lot of you are familiar with her work on adherence. I think it's been probably the best work on adherence that's been conducted. Two grad students and Kelly and I did this chapter. Both of the grad students are now working on their doctorate, so it's always fun to involve really good doctoral students in work like this. We talk in this chapter about the importance of of our understanding of tying communication into outcomes. We tie it in, of course, to adherence, satisfaction, malpractice, various patient variables, and then the pathways from communication to those outcomes, building on some research that Rick Street started, and then his a former student who's now in Singapore, Xiao Jiang, one of my favorite young scholars, has really done the most crucial work on that malpractice. So we had to put a judge in here. Then we move on to some organizational titles. Over the years, there has not been as much research as many of us would like to see on the organizational aspects of health communication. When we first started the journal, I really thought more would emerge along those lines, but it hasn't. So perhaps I can encourage some of you to take a look at more of those organizational issues. We do have some important chapters here. Marty Clayton and two other colleagues of hers, all three of them at the University of Utah, and all three of them with nursing backgrounds, help us broaden our perspective so that we don't focus just on physicians as healthcare providers. So we began this theme with the second edition of the book and expanded it even more with this edition. All types of nurses, physicians, physician assistants, chaplains, other spiritual healers, social workers, various types of therapists, genetic counselors, etc. My favorite are the housekeepers and the role that they play in health communication, something that I think we don't focus on enough. But fortunately, Marty Lee and I'm blanking on her first name, Dr. Pierman, share with us the important role that housekeeping plays in healthcare organizations and with patients. Then we have a chapter that continues a theme that goes back to the first edition of the handbook, Interpersonal Communication, healthcare teams. But we expand it beyond what we have done in the past by talking more about patient handoffs. When one healthcare provider passes the patient and the records on to the next healthcare provider who will be working with that patient. As many of you no doubt know, this is a very interesting and important line of our research. So we finally have some discussion of that in the handbook. We got a team here. And then stress and burnout, not new to the handbook, but even more relevant, certainly during COVID. The research indicates to us numerous things beyond COVID that have played roles in terms of emerging stressors. Much increased reliance on health information communication technology, which in some ways makes our jobs easier, but in other ways makes them much more stressful. Related to that is communication load. The load for healthcare providers has increased massively over the decades, as can also be seen with health systems restructuring, particularly mergers and acquisitions, and the stress that provides for us. Burnout is an important dimension of all of this, of course. Emotional exhaustion, depersonalization, and reduced feelings of personal accomplishment. And as you would hope, support also comes up in this chapter, because that's how we deal. Besides quitting our jobs, that's how we deal with stress and burnout, is through support. The latest data from the U.S. showed that just last month we had more people quitting their jobs across fields than in recorded history. Burnout is not unique to health organizations, but is especially relevant. Although the data in the U.S. showed that in the hospitality, hotel and restaurant fields, we have the highest levels of people quitting their jobs and looking for something that will be more rewarding. We've got someone here who's burnt out then. Moving on to mediated communication, we have a chapter with kind of a different take than we have had with previous editions of the handbook on health and media, looking at the impact of news and entertainment. The first two editions of the handbook really took more of an interpretive focus on this issue, and we wanted to make sure that we also included the wide range of more social scientific research that's been done on this topic. So I think we've been able to accomplish that in this edition of the book, much on depictions of violence, depictions of the environment, body image, risky behavior, diversity concerns, interesting discussion of celebrity impact, and entertainment education. We've got a celebrity here, Whoopi Goldberg. I've seen her on television recently discussing some health issues. I don't know if she has been available to you, but it's just a sampling of the kind of celebrity presentations we see. I think it was just last night I saw Whoopi talking about a migraine medication. Apparently I think that's what it was. She suffers from migraines and was talking about this medication. Now, this also ties in, of course, with consumer advertising and health communication. Direct to consumer advertising is relatively focused just in the United States and New Zealand, but other advertising of health and pharmaceutical products is more widely disseminated across the world. So we have a nice discussion in here by some folks whose work emphasizes advertising. Sample ad here. Then a new chapter on social media and health. When we first started putting together the first edition, none of us ever envisioned that social media would be such a part of our lives, but now we know that it is, and it was important to have a chapter covering this. So it talks about health information support, crisis communication, campaigns as they use social media, and mental health. And we see something that we all see all the time, a bunch of people on their phones accessing probably social media. I remember being in a restaurant a few years ago and looking at a table across from me. 4 people, looked like a family, parents and 2 teenage kids, all 4 of them on their phones. And I was talking to the waitress, and I said, wow, doesn't that capture the world in which we live? And she said, yes. And we shook our heads a bit. And she said, it's better than it was when they walked in here, though, when they were all fighting with each other. So I thought, well, that's something interesting. I hadn't thought about that as a benefit to our phones and social media. Maybe we can stop fighting with family members, at least for a while. All right. And then what a great topic you see covered in this next one: health misinformation. We can't have a volume on health communication without covering health misinformation. I wanted to put in a picture of Donald Trump here, but I resisted. I think I deserve a little credit for that. Just kidding about that. But this is a great chapter on health misinformation. Jali Nan and 3 of her students or former students identify for us various sources of health misinformation, its prevalence, its characteristics, content and diffusion, its impact, and then how it can be mitigated. Don't you think we need a book on this topic? I think that would be good. Danger due to misinformation. Next chapter, or next section, focuses on campaigns, interventions, and technology applications. Some of you may recall that in the first and second editions of the book, we had 2 chapters on campaigns. We have combined those into 1 chapter in this book, and then broadened the discussion of other types of interventions and talked in more detail about technology applications as they relate to health change. So Cami Silk, Chuck Salmons, several other authors shared with us a very important chapter on public health communication campaigns. We gave them a few more pages in this volume than we allotted to the other chapters because of the broadness and importance of campaigns to the field of health communication. When the journal Health Communication first started, I was primarily receiving submissions focusing on provider-patient interaction. People did not realize at that point, we're going back to 1987, 88, 89, the importance of health campaigns as a part of health communication. Well, boy, has that changed. And now we know what an important area of study this is. So we've got a great chapter summarizing very important research on this, a sample, a message from a campaign on asthma. Also focused on intervention, then a chapter on community-based health interventions, whereas we typically think of campaigns as being more media driven. Well, we know that community-based interventions are more likely to impact people, especially as we involve people in the community in these campaigns. So this chapter and a couple of the subsequent ones really bring that nicely in focus. So this chapter talks about health information technology, community norms-based campaigns, and interestingly, communication capacity building interventions. How can we leverage and build people's communication capacity so that they don't have to be told, you should do this, you should do this by those designing campaigns, but they can be much more involved in designing and developing the campaigns themselves, leveraging then their communication capacity. Some protesters here campaigning, focusing more specifically on technology-based information. We begin with the chapter, or this chapter begins with a focus on how effective they are and when they are versus are not effective. And of course, they frequently are very effective, tying them into health promotion and disease prevention and treatment. Key notions of tailoring and interactivity are very nicely discussed in this chapter, as is the notion of formative research, the need for reliance on theories, and then the addressing of health disparities, inequity, diversity issues. Also focusing on technology, a great chapter by Ron Rice, Shyam Sundar, and I think one of Shyam's former doctoral students who's now a faculty member, talking about e-health, m-health, a-health, affordances, tailoring. How cool can you get? We have a picture here of some wearables. Just a great chapter. I think we need a lot more books focusing on this, so perhaps some of you. The book then concludes, as you would hope, with some overarching issues. Health information seeking applies to all aspects of health communication. Who seeks? How do they seek? Who does not seek? Who is health avoidant? So 3 Israeli scholars took this chapter on at this time. They begin with a great discussion of the relevant theories, contexts, the populations for which this is particularly relevant, various methods, measures, and channels that are used for health information seeking, and then some methodological advances in research in this area. So we take a look at this. We got a lot of health information seeking going on. I see 2 computers. I see 2 phones. I see a book. We're searching for information in a variety of different ways, something that most of us do a lot of the time. Then a focus on literacy, inroads into healthy decision-making, the role of health literacy in health communication. This chapter focuses on the paradigms on which different scholars rely as they study health literacy, because there are some very different lens-based versus toolkit-based approaches. There are those approaches that rely more on an understanding of culture, and those that rely less on that. So Nihama Lewis and her colleagues start the chapter off with a discussion of this, talk about populations, for which this is especially relevant, how it can be measured, and then various models. This may be, to me, the most interesting part of the chapter. So something for you to look forward to. We've got some people here who I'm assuming are trying to increase their health literacy. Then communication, health, and equity, structural influences. Vishwanath is the key author here. I'm guessing many of you are familiar with his wonderful work. He and his colleagues at Harvard have been really delving into these equity issues as they relate to structural influences. And I'm guessing that many of you are already familiar with the need to take that kind of perspective instead of looking at individual differences in health literacy or competency, the need to look at the structural influences. So they talk about social drivers, ecological influences, culture, of course, socially constructed harms, how those are built, various policies and social networks, and then access to and engagement with health information and platforms, something to which not everyone has equal access to or engagement with. I just love this chapter. So, group of diverse individuals. Then another wonderful chapter on intercultural health communication. Elaine Shai, I believe the last name is pronounced, just occurs to me that I may not be pronouncing it right. Hsieh. So some of you can probably correct me on how Elaine's last name is pronounced. She begins this chapter also talking about, as I mentioned with the last chapter, about conceptualizing culture, as it's traditionally seen as various groups or as speech communities. So some nice incorporation of the different perspectives there. She also talks about culture as worldview, medicine as a worldview, religion as a worldview, those people who come from hostile lived environments as part of their culture. We certainly see that a lot with refugee issues. And then culture as a living process. I think this chapter is wonderful. How many times have I used that word wonderful today? We don't want to count. That's one of the things that students sometimes count in our classrooms, isn't it? Just as they count how many times we say and one can count how many times I say that, as well as how many times I say wonderful. We see an intercultural group here, and then another great chapter on global health communication. We had some difficulty getting this chapter brought to press because most people who are really interested in global health communication are so busy doing development work that they don't have time to write chapters for us. It's the same thing with the environmental chapter, which I will talk about in just a moment. But we finally got Doug Story at Johns Hopkins to write what turned out to be a great chapter. It was worth the wait. So he talks about priorities and gaps in global health communication scholarship, cross-national theorizing and comparative study, the mainstreaming of global theories, and the quest for impact at scale, as well as sustainability of our global health communication efforts. I think you will love that. Public health crises. At the time that we invited Ann Neville Miller and Lindsay Neuberger to write this chapter, we did not know how relevant crises would be to us. They start by talking about organizational factors, messaging channels and characteristics, various types, infectious diseases being something of which we are all way too well aware, but also natural disasters and human-caused disasters, something of which some of us are not as aware as we should be if we look at some of our politicians and world leaders. Various theoretical bases for the study of this, stage models, crisis response approaches, and organizational learning theories, and then some important suggestions for future research. And all of the chapters end with some discussions for future research, but I wanted to mention it particularly in regard to this chapter because they have an especially nice discussion of culture and inequities as they relate to these crises, the role of social media, and of course, misinformation. We've got a disaster pictured here, which I hope was environmentally caused or a natural disaster rather than caused by humans, but could well have been caused by humans. I'll stop commenting on that. This next chapter is also a new one for us, communicating about the environment. Environmental communication is a new and important area of study, and this chapter, of course, focuses on how it relates to health issues. This too was one that we had difficulty getting someone to write about. People like Ed Maybeck, who do great work on environmental communication, are much too busy being activists to write chapters, but we finally convinced Amy Chadwick from Ohio University, and she did another chapter that was worth the wait. She talks then about the social construction of the environment, particularly as the media coverage and framing of it are part of that social construction. Factors affecting public responses, political ideology more in some cultures than in others, various risk-benefit analyses, and again, social support, environmental health literacy, design issues, some organizational issues as she looks at NGOs, government organizations, industry, and health organizations, and then various movements that are a part of environmental health communication. Our world and its environment, finally some challenges and challenging contexts. Some ethical issues in health communication. This chapter is a little broader than it was even in the earlier editions of the book, in that we talk about clinical, digital, and campaign issues and the ethical concerns that are relevant to all of those. I'm thinking this person is having these people are having a discussion about an ethical problem. That's why I included it. Then a chapter on rethinking imbalances of power through health communication, challenges for scholars, practitioners, and activists. A very important focus on race, ethnicity, indigeneity, is that a word? Perhaps I'm just making that up, but indigenous people, sexual orientation, transgender perspectives as it relates to health communication, something to which all of us need to draw our attention much more strongly in our research. We've seen quite a bit of a discussion about that in the last few years in the field of communication. And then a chapter, only because it's a challenging context, on conversation analysis. I think that some of the most interesting findings related to the interpersonal aspects of health communication have come from work on conversation analysis. So we've had a chapter on this in all three editions of the book, and it keeps getting broader. This chapter begins with action agendas as they are shown through conversation analysis, as well as sequence of organization of healthcare interaction, the positioning of actions relative to outcomes. Some of you are probably familiar, for instance, with John Heritage and Jeff Robinson's work on the difference between asking, do you have any more questions or do you have some more questions? Love to see those head nods. I'm glad you're familiar with that. So then a focus here on from interaction to outcomes, really important, but talk about challenging work to do, a health conversation. And then, as those of you who are familiar with the earlier editions of the book know, we usually try to include a discussion of some particularly important issues and controversies in research design and data analysis. Brian Sothwell, Marco Weiser, I may be mispronouncing his last name too, although I communicate with him all the time. You'd think I know, I would know better. Mike Stevenson, and now a grad student who they brought on board, which probably means that she did most of the work, don't you think? Isn't that that how it usually is? So they have built on what they wrote in their earlier versions of the chapter and extended it even more. Just a great contribution. We've got a health communication researcher here, deep in thought. And then we had Brad Hess. We finally convinced him to write a chapter for us. He had stepped down from his role at the National Institutes of Health. We waited just long enough for him to be past the point in his contract with them where he could write about the things that he had done. I mean, just past it. It was up in July. He started writing for us in August. So this chapter focuses on health communication research and practice at the level of government, foundations, public policy, and NGOs. What a nice contribution. I love in this chapter how he talks about a platform for impact. The impact that health communication scholars and researchers can have at this level. An investigator-initiated research portfolio. Don't you love that wording? Oh, wow. I'm going to have to throw that into a conversation somewhere. The importance of surveillance research, knowledge synthesis, and he concludes with something that really warms my heart. A call to service. I think you will like that. Some government people. These just look to me like government people. Finally, then, the book concludes with some challenges in gaining access and conducting your research. Roxy Parrott had written kind of earlier variations on this, as had Gary Krebs in some of the earlier versions of the book. We brought a couple of new people here, and I thought it was appropriate to share a new contribution. So they talk about the difficulties of gaining access to health organizations, the importance of working in communities, and realizing the different perspectives that are a part of these different communities and how we can work together, working internationally and the unique challenges that presents, addressing IRB concerns, something we all love to talk about, staying abreast of scientific knowledge production, navigating the publication process, and then concluding the chapter with some lessons learned, building relationships. They focus on being issues, being humane, being flexible, being multidisciplinary, seeking multiple perspectives, and being ethical. As this chapter concludes with approval, research that has been approved, as we talk again about IRB. So that is an overview of the handbook. I have no idea how long I have talked. I'm hoping that I talked about as long as Bernadette asked me to, but I'm hoping now that I can stop sharing my screen and that we can all talk about some of these issues. What do you think, Bernadette? Do we have time?
We do have time. You spoke for just about an hour, and that was great. Thank you very much. And I mean, you've blown me away by the scope, breadth, depth of this new handbook. I mean, this is some really new stuff there. It's very exciting. And I'm longing to get my hands on it, I have to say. So that is great. I mean, the whole thing, I can't possibly name them all, but the importance of stigma, which is something I'm researching at the moment myself.
Oh, good.
The difficult conversations, you know, and how I was talking to a colleague not long ago, and they said, you've got to recognize that people don't like them to be difficult, but you have to confront that they are difficult and you're not going to feel comfortable. And you have to get used to not feeling comfortable. Don't avoid it. You know, the whole thing about the global aspects, technology, and of course the problems with technology, that it does make life easier, but it can also cause so many problems when you've got clunky systems where people don't put something into the computer because they can't get to it. All those things which mean communication fails. All those are wonderful. So I'd like to open it up to the floor. If anyone has anything they would like to either ask using turning on your microphone, or typing a message in the chat. Does anyone have some questions for Terry Thompson? You deserve that gulp of water.
Thank you.
Anyone? Yes. Hi, Mel.
Hi, Benedict. Thank you for that talk. That was fantastic. You're a busy woman.
Thank you.
I just out of interest, because it's my area of research, you talked about difficult conversations between clinicians and patients, but I was interested if you covered difficult conversations between clinicians, like speaking up and those kind of conversations.
Boy, that's an excellent a question, Melanie. And that particular chapter does not talk much about those a difficult conversation, but the chapter that Kevin Reel, Ann Streeter, and Scott Poole wrote, which discusses interprofessional team communication, does talk about that some. We need more about that. I'm going to start making notes for the fourth.
Not that you're going to organize it, but you can start making notes.
That's right. That's right. Maybe I'll have you two do it.
Well, Mel's my PhD student, so yes.
Good.
Doing very interesting work on speaking up. Yeah, so yes, that is something that needs to be looked at and reassessed. Any other questions from people? Yes, Stephanie. Hi, Stephanie.
Hi, good morning. It's lovely to meet you, Dr. Thompson. And I'm really excited to hear that there is a section on stigma and communication and health. And my research actually looks at, I'm in Hong Kong right now, which is why it's the daytime. And I'm looking at how stigma can manifest at multiple levels. So, like at the population level and at the level of interpersonal interactions in the daily context. And I'm looking at mental health stigma in particular. And I'm just wondering whether there is something. I know that there are different chapters that cover aspects of that. So I see that there's a stigma communication in health, and also applied research. And also like community-based interventions. But I'm wondering whether there's anything in particular on mental health stigma or, culturally adapting interventions to the contexts that are relevant. But yeah, I would love to hear what's
yes, those issues, so important, are covered in a number of different places throughout the book. So the chapter on stigma, Rachel Smith and a colleague, he includes a discussion of particularly how the research on stigmatization and stigma theory applies to mental health. And then, as you can imagine, the chapter on mental health talks about the role of stigma there. And all of the chapters that deal with cultural concerns will tie in. I guess you're going to want to get a copy of that. Have your library open, order it. Be the first one to check it out. Wouldn't that be good?
I will definitely be checking this one out. Thank you so much.
No, I think I'm looking at stigma and lung cancer, and how people who get lung cancer are bad people. It's really interesting. Both my colleagues Stefano and Liz Jones, and also Ivy, who's a PhD student, we're all looking at that and looking at the difference between Australia and Hong Kong.
Fascinating. Good.
Big
Can you share with us a little bit about what those differences are already?
Well, now, Ivy, would you like to? Ivy's sitting here, my PhD.
Oh, good.
Hi, Professor Thompson.
Hi, so nice to meet you.
Nice to meet you. I've heard so much things about you. And we don't think we have the comparison results yet, but we do have some preliminary results of like how Hong Kong people might think of people with lung cancer.
Good.
And how that, there seems to be some evidence that people are morally bad who have who have lung cancer, whereas but in Hong Kong we notice in the interviews it's mixed methods. We notice that often they'll talk about people not what's the word, just lost it for a moment. People, the environment, it's not always their fault.
Right.
That seems to come out a lot more than it does in Australia.
Interesting.
The Hong Kong interviews as well.
Yes, interviews, yes. That,
good.
It's just the way people have to work, their conditions, and then they get cancer. So it's a very interesting area.
And environmental pollution.
That's right.
No one's fault, but they have to do that.
So that's an interesting one. But,
indeed,
yes.
I know I have many times heard people say so-and-so has lung cancer and he never smoked a cigarette in his life, feeling a need to add that to avoid
they're not
stigma.
A bad person. They didn't smoke.
Yes. Wow. Yes. Wow.
Any other?
I will look forward to that. Keep health communication in mind as an outlet for that research. Speaking of which, Bernadette, I owe you a response on a submission, which I'm going to try to send tonight. I promise.
That's actually with Ivy and myself. So
good. Good. Excellent. Excellent.
And any other questions from the floor? Anyone would like to say something or write something? Some people might be getting sleepy. I know some people have to go off to other meetings. I'm so pleased it's recorded. I would like to ask you something myself, though, Terry. Over the years, since I've been doing it, we've moved more and more away from being atheoretical to using theory. How do you think we're going now? Because not that long ago, it might be 10 years now, but that doesn't seem that long to me.
No, me neither.
People were still saying it's not enough being done. What do you think about that?
I have seen great progress. It is now rather rare that we publish anything in health communication that's atheoretical. Almost everything is theoretically based. Oh, and I should mention this. Peter Schultz and I had a book come out just this year on health communication theory. What's it called? Health Communication Theories, I think that's what it's called. I should not have difficulty thinking of that. Wiley Blackwell published it. And that was the book that with which I had the most difficulty I have ever had with authors, getting them to complete their chapters. Just as a side note, I've never before had authors who, I forgot I agreed to write that chapter. So that one took a lot of work to come to fruition, but it's out now. As we were pulling that book together, it became apparent to us just how much change there has been in the study of health communication in terms of reliance on theory. Less so in some areas of health comm than in others. In the provider-patient literature, there's still very little work that's theoretically framed. There are Peter, my co-editor, and then Xiaohai Jiang, whom I mentioned earlier, co-authored the chapter on provider-patient interaction. And that was a tough chapter to do because there's not as much in terms of strong theory. That work tends to be more context-driven rather than theory driven. Rick Street is really one of the few people who's done much theoretical work on that. So all of his stuff on patient-centered communication is, of course, a nice base for it. But all of the campaigns research tends to be theoretically focused. We do find a little bit of a difference. Well, quite a bit of a difference depending upon the background of the scholars. Those scholars whose backgrounds are in communication or any area of the social sciences are much more likely to frame their work in theory than are those with a background in medicine, who are not taught theory. So that's a fundamental difference. Public health scholars also do not tend to rely quite as much on theory as do other scholars who study aspects of health communication. I was Zooming, was it night before last, with a young doctoral student from Indonesia who wanted to talk about his dissertation of research, but there was very little theory in the public health program in which he was participating on which he could build. So our focus has kind of been, how can you frame the model? He was interested in looking at smoking behaviors, particularly amongst young teenage males who smoke on a daily basis. He wanted to develop a model, but was not being trained in the theories on which most of us would rely in such work. So we find a bit of a difference, and it's kind of obvious with submissions what background someone has when I receive a submission, in that with the social sciences and health communication scholars in particular, almost all work is theoretically framed. So that's good news.
Yes, that's music to my ears, seeing as I'm a communication accommodation theory person.
Exactly.
Give it a plug.
And Bernadette, you know about that theories book because you have a chapter in it.
I know. I was wondering whether I was one of the recalcitrant authors.
No. You were not, although if you recall, I had to bring you on to replace someone who did not come through. Do you remember?
I do.
Okay,
I do.
we'll stop that. Thank goodness I was able to bring you on.
Thank you. No, and I was very pleased to be involved along with Rachel Pines looking at communication accommodation theory. Yeah, that was good.
Wonderful.
So I guess we're sort of drawing to a close. If there's any last questions, please don't hesitate. It looks like possibly not. I have so enjoyed your talk, Terry.
Thank you.
And, I just, again, I'm blown away by the scope of the book and the amount of work that must have gone into it. So, wow, all the authors. I'm looking forward to getting this third edition. But I think you will love it. I think I will. There's going to be stuff in there I really want to look at. I also want to see more about East and West too coming together. That's a future direction.
Yes,
the role of traditional Chinese medicine and Western approaches. I think that's an interesting area too, which our centre is hoping to look a little bit at.
Good. Good. That's great.
But let me put my hands together to thank you so much. I know.
Thank you.
And I really appreciate your time, and I look forward to reading the book. And
Very
Mel,
good.
did you have a last question? Is that why?
No, I was just going to say thank you.
Oh, thank you. Just another.
Thank you. I
Thank
appreciate
you so
it. Thank you, Stephanie.
And thank you for your time. Bye
Thank
now.
you. Appreciate it. Take care. Have a good day. I'll have a good night.
Sleep tight.
Thank you.